morning, everyone. So according to my watch up here, it's 9:15, so I'm going to go ahead and get started. And I'll just start with an introductory comment, and that way, because the people that are coming in late won't miss too much. First, in terms of housekeeping, I actually have to get to the airport shortly after I finish my lecture, so please pick up a handout. You'll find on the back of the handout my email address. And then also, I left some of my business cards. So if we don't get to your question, please feel free to send an email or contact me, and I'll be happy to answer them that way. So the second kind of administrative business point is this talk. I've given this talk for years, and I just want to be clear that this is localized scleroderma or morphea. So this is not the same thing as systemic scleroderma or systemic sclerosis. So if that's not what you're looking for, I just want you to be aware now so you can change and attend one of the other excellent lectures that are going on now. So with that, my name is Heidi. I'm a dermatologist at Southwestern Medical Center in Dallas, Texas. And my practice is exclusively, almost exclusively seeing patients with morphea and also scleroderma. In addition to seeing the patients, I actually am the principal investigator for the Morphea in Adults and Children cohort. And the purpose of our cohort is actually to enroll people with morphea of all ages and follow them annually to better understand the natural history of the disease and the effective treatments on that natural history, as well as the impact on life quality. In addition to gathering that information, we actually do gather blood and skin samples from patients and have a number of ongoing studies, which I'll just touch on briefly today to try to better understand what the pathogenesis of morphea is. So that's my background, and what I really aim to do today is kind of let you guys learn a little bit about what the other diagnoses are considered when we see a patient with morphea that your doctors should be aware of when they're examining someone with a potential diagnosis of morphea and things that they need to eliminate. Also, to understand a little bit about what we think is going on in the skin in patients with morphea, and that in fact might be a bit different than what's going on in scleroderma. Understand what there are that distinguishes patients with morphea from scleroderma, because if I can leave you with any one point today is that these are two different entities, and having one does not mean you will get the other. And that's actually an important and key fact for today. And then a little bit about treatment, so you can perhaps make some better choices for you or family members that might have morphea. So the first thing to think about is we as dermatologists, actually, when we think of disorders that cause thickening and hardening of the skin, which morphea and scleroderma are part of, they actually are the result of an abnormal function or a proliferation or increase in the number of cells in the skin called fibroblasts. And what fibroblasts do is that they make collagen. And if you stimulate fibroblasts, they can spit out collagen in huge quantities. And you can also create an environment where your collagen is not degraded. So that's one of the essential abnormalities that binds together both scleroderma and morphea. And unfortunately, my pointer is not working very well, so I'm just going to point here. So you can see that these two disorders, what they're linked by is the fact that there's too much collagen in the skin. And so that is the process that is going on. There are other disorders that cause thickening and hardening of the skin that are listed here, all these fancy names, but they're actually all different because if you look at them under the microscope, what you can see in some of these is that you actually have not just more collagen, you have more cells that make collagen, and in addition to collagen, you have something called mucin, which is really just mucus. It's like this very jelly-like material in the skin. Some of these have both mucin and too much collagen, and then some just have mucin alone. But the reason why morphea and scleroderma get grouped together is because they are both disorders that are characterized by too much collagen in the skin. And so sometimes when we take a skin sample and look at it under the microscope, they look very similar. The important point, though, is that they are very different in how they behave in the people who have these disorders. The other point here is that when you see someone to be evaluated for Morphea or Scleroderma, they should also consider some other disorders that are listed here. One of the big ones that we see a lot that's misdiagnosed is something called lipodermatosclerosis. And that's actually something that is in adults with thickening and hardening of the skin of the legs that is related to a number of factors, including being overweight, having had hip replacement or knee replacement surgeries, and venous incontinence from varicose veins. But I routinely refer patients who have been told they have Morphea who in fact have lipodermatosclerosis. The second thing to be aware of is this entity here called GVHD, which is graft versus host disease. And interestingly, this is something that people get after usually a bone marrow transplant. And they after several years after their bone marrow transplant, they can actually get skin lesions that look very much like Morphea or Scleroderma, but in fact it's related to their bone marrow transplant. The other entities here are rare. There's a type of porphyria that can cause thickening and hardening of the skin. And the other one I would point out to you is that there are some exposures to drugs that give you Morphea-form skin lesions. An important one to know about are taxane chemotherapy drugs. They are commonly used in the treatment of breast cancer and also in some cases prostate cancer. And in these cases, patients can get thickening and hardening of the skin of their arms and legs related to that chemotherapy agent. And I've also seen them referred to my office with the diagnosis of Morphea and or even Scleroderma. The reason this is important to differentiate is this usually improves after they stop the chemotherapy. So it's a different entity that is promoted by that drug. It's not the primary process of Morphea or Scleroderma. So these are some things that your doctors should just be well aware of as they evaluate you, and they should be things that they ask on the history as they take the history and do the physical exam. All right, we're going to get a point over here. So this is just a larger list of entities to consider. And so when you see someone, it's important for them as a physician or provider to go through these entities. Now, I will tell you from a practical standpoint, for children, usually pediatric dermatologists and pediatric rheumatologists are good at these, distinguishing these disorders. In adults, the case is actually a little bit different. Adult dermatologists are not very good at managing Morphea simply because they don't see a lot of it. So, if you are an adult with Morphea, you are probably better off to see a dermatologist, and in particular a dermatologist that identifies themselves as a medical dermatologist. Medical dermatologists are oftentimes at big medical centers or medical schools. They also have a website called the Medical Dermatology Society, which lists their membership. So it's a little bit different in terms of which types of care providers that you need to seek out based on the age of the patient. So when I see a patient, I think it's very important to ascertain these following elements that you see here. The first is really to elicit a history from the patient. And what's really important to figure out is, do they have any concomitant health problems or concerns or issues going on, and what treatments they've had to date and the effects of those treatments. And remember, we talked about that radiation as well as chemotherapeutic agents can cause skin lesions that look like Morphea. So I always ask them if they have recently had any exposures or treatments for cancers. And I also look for any inciting events, which means have they had surgery or radiation therapy before these areas started. The really important thing is the distribution of lesions and the progression. And what you'll see is when you move forward, one of the things that really differentiates Morphea from Scleroderma is where the skin lesions are located on your body. Morphea and Scleroderma skin lesions are located on very different parts of the body. So I always want to know, where did they start, how did they evolve, how did they progress? And the other important thing is with Morphea is to understand if those spots are active or inactive. So I'm very interested to know, are you still getting new spots? Are those spots you have still enlarging, or are they more just sitting there? And these are important things to also consider for yourself or your family member who has morphea, to pay attention to these factors, because these will be better able to, if you can provide this information, it will allow your care provider to make better decisions about treatment. I sometimes do blood tests, very rarely. They're not terribly helpful for morphea. And then I always do a very thorough physical exam. I find routinely that patients sometimes don't know they have morphea lesions in areas such as their back that are difficult to see. So I do ask them to remove their clothes so I can look at them all over. It's very important to do that, because if they come in later and say, oh, I have a new spot, and I have not examined that area previously, we might not be sure. So it's very important, again, for a patient or care provider to really take a look everywhere and see if you can find where all the spots are, so you know the extent of the area. And occasionally, biopsies can be helpful. Remember, we talked about before, there are a bunch of disorders that can cause thickening and hardening of the skin. So taking a skin biopsy can help us differentiate between those, because in morphea, we should see inflammation and increased collagen. Some of these others, what we'll see, are more of those fibroblasts that make collagen, and collagen, or just the mucin, which is the mucus in the skin. So a biopsy can really help us out to differentiate them. What is important to know, though, is a biopsy will not differentiate morphea from scleroderma, because remember, they're both a lot of collagen and not a lot of fibroblasts. And this is the problem for a lot of people with morphea, because what happens is they see a provider in their community who does a skin biopsy that's sent to a pathologist that then signs it out and says, compatible with scleroderma, clinical correlation is recommended. And what that simply means is, oh, the skin looks like it could be someone with scleroderma, but you're supposed to, the care provider is supposed to go back and look at the patient and see where their skin lesions are and what's going on with them, and then ascertain whether they have scleroderma or not. The problem is, because this is rare, a lot of people don't really know what clinical features differentiate the two. So when they see this, they just say, oh, you have scleroderma, and send you to a rheumatologist. And this leads to a lot of misdiagnosis and stress and confusion for everyone involved. So again, I hate to harp on this point, but it's so important for my patients, and I think that the relief I see when I have these discussions with my patients is so palpable. I think the point is really important. Scleroderma is not the same thing as morphea. And the other really important thing to know is that I follow 500 people with morphea. None of them have developed scleroderma. Okay, so what that means is, if you truly start out having morphea, you will have morphea, but it will not at some point change into scleroderma. If you start out having scleroderma, that is what you will continue to have. The two don't really change between one another. And the internal manifestations and implications of the two are very different, which we'll be getting into next. So the cutaneous manifestations, i.e. the skin manifestations of scleroderma, are the hand changes. And usually I can tell if I have seen a patient for the first time if they have scleroderma or not, simply by shaking their hand. Because scleroderma almost universally starts in the hands with Raynaud's phenomenon, and also the thickening, or initially it's just swelling of the fingers that then eventually leads to hardening of the fingers, and then oftentimes even thinning and contracture of the fingers. This is not present in morphea. There are two types of scleroderma, and the nomenclature is based on the parts of the skin that are affected in scleroderma, diffuse and limited, which are here. Diffuse, all diffuse means with scleroderma is that the skin thickening and hardening goes proximal or above your elbows, and frequently involves the trunk as well as your stomach and back. Limited means simply that the skin thickening stays below your elbows and mainly on your hands. But both of these, even though this is so confusing, are scleroderma, and both of these still have the potential for involvement of the GI system and the lungs, as well as the kidneys and all the internal manifestations. So remember, if someone says diffuse and limited, skin lesions in scleroderma. It doesn't mean anything about the internal. So the other thing about scleroderma is your doctor should do blood tests, and most people with scleroderma have very particular abnormalities of their blood tests, which include anti-nuclear antibodies, SCL70 antibodies, centroid antibodies, and RNA polymerase antibodies. And these are also absent in Morphea. People with Morphea do not have these. And then people with scleroderma have a very characteristic internal organ involvement. Most commonly, it includes the GI tract, the lungs, and the heart, and sometimes the kidneys. Again, this is absent in Morphea. So you can see that these are kind of the hallmark characteristic features of scleroderma, and people with Morphea do not have any of these. Now, I do know there are some patients with Morphea who have Raynaud's, but it's also important to remember that Morphea is a female-predominant disorder, and women can also have Raynaud's or primary Raynaud's in the absence of scleroderma. So we very rarely see patients with Morphea with Raynaud's, but that would be the main thing. But what I hope to make clear is that if you have Morphea, you should not have these particular features.
The features you shouldn't have is the GI, the lung, the heart.
And also the skin is different. You shouldn't really have the Raynaud's, and you shouldn't have the thickening of the skin in the hands on both sides.
Okay.
So just to kind of illustrate this point, I think sometimes pictures are worth more than 1,000 words. And then you guys might be very familiar with this. So this is a typical patient with early scleroderma. And what you can see here is just little post-Raynaud's changes on her fingers. Also the thickening of the skin of her hands. Her hand mobility is still well maintained here, but you can see that the skin is thickened, her fingers are a bit tapered, and she has early inflammation with a bit of redness on the hands here. Moving forward to the more sclerotic phase, as in this gentleman, excuse me, you see here again the thickening of the hands on the fingers, and it's symmetrical on both hands. You can also see pitted digital ulcers and the scars from them that are the result of the Raynaud's and the vascular disease. And you can always see patients with scleroderma, if you look at the folds on their knuckles, the skin is actually thickened. And if you compare it to someone without scleroderma, you'll see that the skin folds are much thinner. Also, if you try to pick up the skin just using your two fingers like this, you'll find that it's very difficult to do that with someone in scleroderma. But again, people with Morphea do not have this. So, what are kind of the features of Morphea? And I won't belabor this point, but this is something that I presented at the New Investigator Conference today, earlier this week, here at the meeting. And this is actually really exciting. This is some of the work we've done thanks to the patients who have helped us in our Morphea cohort. And what we were able to do actually here is look at the skin lesions of people with early inflammatory Morphea and do something called whole genome expression analysis. And basically what this tells us is which genes are turned on in Morphea skin, which are turned off, and which are about the same as normal skin. And what we see here is that this test, this study was clearly able to differentiate the skin affected by Morphea and the skin that was not affected by Morphea. So, and the patients clearly separated into two groups, the non-lesional skin and the lesional skin. Now what's exciting about this is two things. One is people have done a lot of these generalized expression studies in scleroderma, and we were able to compare our results with those that have been done in scleroderma. And what's interesting is it's dramatically different. This is the first time anyone has really looked at the molecular pathogenesis of Morphea in depth. Until now, everyone just assumed it was the same. So people would do studies with patients in scleroderma, and if you read a Morphea textbook, they would put that in there as that was what was going on, but they were just assuming they were the same. This implies they're not. So it makes sense because, as I told you, the clinical manifestations are so different. It would make sense that what's going on actually under the skin in a molecular level is also different. And what's different is right here, and I understand you can't read this very well, but what this shows is massive inflammation in the skin of Morphea. Not collagen, not fibroblasts being activated, but massive inflammation. And in particular, we saw something called CXCL9 and 10 in the skin of Morphea, which is a predominant factor in skin diseases like psoriasis and lupus and things like that. These are not prominent in Scleroderma. We went on to actually look in the blood of people with Morphea at the levels of CXCL9 and 10, and they were much higher in people with active Morphea than in healthy controls, and also in people who had inactive Morphea. So we actually think, and we need to do a lot more studies to confirm this, that CXCL9 and 10 might be indicators of active Morphea that we can actually use in the form of a blood test. So this is very exciting for us, and we're actually about to submit this for publication and do some more follow-up tests. But these are the first hints that actually, when you look at this in depth, and study Morphea in depth, that it might in fact have a different initiating process than what is happening in Scleroderma. This is excellent too, because this gives us some targets for therapy that we can potentially exploit. So let's talk about, we talked a little bit about the skin and internal organ manifestations of Scleroderma. So to contrast that, let's talk about the skin and organ manifestations of of Morphea, sorry. So one thing that has been proposed by two pediatric rheumatologists named Francesco Zulian and Ron Laxer is this classification scheme. And I think it works pretty well for most patients with Morphea. And we'll follow this up with some photos. So the first is called circumscribed or plaque Morphea, and these are usually just oval or round indurated plaques. The second is generalized Morphea, and this is sometimes the one that gets confused with Scleroderma, because what generalized means is you have spots kind of affecting a large part of your skin. And the official definition is right here. The rarest version is called pan-sclerotic Morphea, and in fact, out of my 500 patients, we only have about 15 people with pan-sclerotic Morphea. And this is confluent, full thickness involvement of the trunk, extremity, face, and scalp. And it ends at the wrists and ankles, which is so interesting because Scleroderma is the exact opposite. It starts in the fingers and moves in, and this starts in the trunk and moves out and spares the fingers. Linear is a predominant subtype in children, and also we see it quite frequently in people into their teens and 20s. People in their teens and 20s oftentimes can behave much more like what we call the typical pediatric onset or linear Morphea. And then mixed, which I think is personally controversial, is a mixture of two subtypes. Usually it's linear and generalized, but I actually think that that might not actually exist. Not much coding modification. The other thing to keep in mind is any of these can have a deep component. So what do I mean when I say deep component? Deep component means that there's involvement not with the internal organs, but just that the lesions don't just involve the skin, but they might go down to the fat underlying the skin or the muscle underlying the skin. But deep involvement does not mean that it will spread to the internal organs underneath the lesions. So this is an example of plaque Morphea, and this predominates in adults. And what you can see here are just these round areas on the skin. If you were to touch these, they do feel thick and hard. This patient, they're not terribly active at this point because they're starting to turn brown. But you can see that this is very different from that is typical if you have seen or have Scleroderma. This is just a generalized Morphea, and this is a gentleman I followed now for several years. And what you can imagine here is that the plaques that we saw in the prior photo continued to proliferate over several months to years. So now these plaques are coalescing or coming together into larger areas. And so generalized Morphea generally evolves over time, months to years, to include these large areas of involvement. But it can start with just the individual round plaques like we saw before. And again, this is more common in adults. So this is the Sclerotic subtype, and the skin involvement here is frequently worse than most people with Scleroderma. And you can see in this patient, she has very tight bound-down skin that essentially involves most of her skin surface. And you can see here this very characteristic cutoff that actually stops right here at her knuckles, and her fingers are uninvolved. And so again, this is the opposite of Scleroderma, which we would expect to start on the fingers and this way. Another characteristic finding here, as they call it the tank top sign, is it comes kind of up and spares the armpits here, and it tends to spare the areola in women and men both. And you can see here that this is a young boy at his feet. It stops right here, again at the same place, and his toes are unaffected. This is linear Morphea, and this, as I mentioned, is the type that is most common in children, teenagers, and oftentimes people in their 20s. And you can see here it's called linear because the skin lesions tend to move in a line or band down the arm or leg, and they tend to move in a line or band across the trunk. And the giveaway here is they stop in what you call the midline, which means it's just a line kind of going down the middle of your trunk. They'll very neatly stop here. And I think that when I say that I don't think mixed subtypes exist is because I find people frequently misdiagnose these and they don't recognize the lesions on the trunk as being linear. And you can have more than one of these. You can have several of these. And you can continue to get more of them over time, which is true of any of these. They tend to take on two forms. One is, again, the round plaques that kind of multiply, and you can see that kind of here, and come together over months to years. And there's another type that seems to come almost as a contiguous sheet very quickly. So it's not so much this coming together of individual round areas, but more of a contiguous sheet that develops rather quickly. Yes? That is a great question. So there's actually a huge debate about that. There are dermatomes that are based on kind of your inner nerve innervation. There's also something called blastoid lines, which are actually how your skin forms as an embryo. And they look slightly different. So there's actually a huge, it most definitively is not dermatomal, but there's actually a big debate about whether it's in this blastoid distribution. And there are people who are huge proponents that it is, and huge proponents that it's not. The problem being is the lines of blastoid are not very well developed. You know, they're kind of muddy, and so you can kind of work it either way. But that's a great question. But they're not dermatomal in the sense of, like, for example, shingles. Okay, so we kind of talked about the subtypes. So when I see a patient, I look for what type of subtype of Morphea they have. The other thing I look for is activity or active Morphea versus damage. And this is really key because distinguishing between these two will determine how you manage the patient and what treatments are appropriate. So activity has the following features: erythema, which means redness, redness or almost a purple look, and kind of when you feel it and touch it, a thickened border. So activity actually is the redness around the periphery of the lesion. New or extending lesions, either I follow people with photography or by history if it's the first time seeing them, and they have that firm, sometimes whitish sclerotic center. Some people actually have itching and pain when their lesions are active, but in other cases we also see pain, not all the time, but infrequently, that continues even afterwards as part of damage. So that can work either way. Damage is pigmentation, so either darkening or lightening of the skin. Atrophy, which means an indentation, either just of the dermal layer of the skin, so that's very subtle, or actually loss of the subcutaneous fat or muscle, which can create a much bigger indentation of the skin. And then also sometimes this thickened skin in the middle. So this is kind of a big job for me, and I look at patients very closely to discern whether they have these features. And it's not uncommon at all for people to have both. So they have older lesions that are inactive and reflect damage, and they have newer lesions when it's active that are coming up that actually reflect activity.
Can I ask a question?
Sure.
Do you see damage in the bones?
You can. And the clinical significance of sometimes if you just x-ray or image bones, you'll see changes in the bones, which is not always clinically significant, i.e. it doesn't always cause a problem. But you can also see, particularly in children, because these bands are tight, it limits growth. And things, so the bone lengths are shorter or they have other bony abnormalities. And sometimes those changes are not even directly related to the morphea getting down to the bone, but just the fact that you have this very tight band that's essentially inhibiting the growth. And we actually use, in my clinic, a storage suite. And this just kind of highlights these activity features here. So this is just an example of someone who has a very active lesion, and this is actually where we did a biopsy. But what you can see is that early active lesions can be quite subtle, so people oftentimes don't recognize them, or they've been told they have ringworm, or they thought it was a bruise. It's exceedingly common because these are subtle, and the problem is because this is such an uncommon entity, if you see your pediatrician or a general practitioner, or even some dermatologists, they will look at this and not really know what it is. And it's unfortunate because this is the time to intervene because these early active lesions are the ones that respond best to the treatments that we have. But you can see here this red, almost a little bit purple-looking border, and in the middle here is the collagen that's kind of this whitish yellow. So if you feel these, they feel thick here, and less thick around here, but it still has some substance, but it's red and sometimes even warm. And you can see it extends down all the way through here, and you can see how subtle these are as they first start. So if you don't know what you're looking for, it can be very difficult to detect.
So,
Yes?
now that turns brown though too,
It
right?
does.
It turns brown.
It does, you're absolutely right. I have some photos for that. So
Yeah.
as it becomes inactive, it turns brown. So,
Okay, that's okay. So
yeah, so the key here is red is active, brown is actually good because it's becoming inactive. The other thing is that just looking is not going to help you with these because they can actually extend beyond where they're obvious. So if you were to just look at this patient's leg, you might think that, this is kind of the area of involvement. And again, you see this central area where the collagen is, and then this subtle redness surrounding it. And in this photo, you can almost see kind of like the follicles are a bit enlarged. And we call this coda orange, skin of the orange change. But if you actually feel her leg, you can actually feel the thickening and induration are extending to where my fingers are. So it's very important that your doctors not only look, but actually palpate the skin and document the extent of this. And you can see I use photos a lot because this really helps me to know how people are doing over time. So damage, in contrast, looks like this. And this is a young boy that I followed for a number of years, and he actually came in exclusively with damage. And we actually see a number of different changes consistent with damage here. So we see the darkening of the skin or hyperpigmentation. We see some lightening of the skin or hypopigmentation. We see here that he's lost some of the subcutaneous fat on the backs of his hands, which make the tendons going to his fingers look more obvious. You can see here also the affected fingers are thinner than these. And so he has many of the manifestations of damage. The thing is that is unfortunate about this case is that most of the treatments that we have right now will be ineffective for people who exclusively have damage. The treatments work when it's active. And so things like phototherapy, methotrexate, prednisone, all the creams that are often prescribed by dermatologists don't do anything for this. And that's why it's important to distinguish one from the other. This is a patient of mine who's in her 50s, and she actually had morphea as a child and teenager. And so you can see here that she has, this is a linear lesion of the trunk, And what you can see here is she has the hyperpigmentation that's faded a lot over time. She's lost the excessive collagen, so her skin is quite soft. But she has lost both dermal tissue, so there's what we call a clip drop or a little bit of atrophy here, and she's lost some of the subcutaneous tissue of her shoulder. And you can see the things that go away over time are the thickening and the redness, and the darkening fades to some extent. But when you lose the tissue, that rarely comes back, so we don't really see it fill back in again. And that's why it's very important to treat when it's active, because what you hopefully are trying to do is to prevent the damage, because once it's there, medical treatments won't really reverse it. This is another example of someone, a teenager, who had a linear lesion of her leg as a child. And you can see here, again, she's lost some of the fat pad around her knee as a result of her morphea, and this has become quite soft, but the skin remains darkened. The other thing here is this illustrates what is different between scleroderma and morphea. Internal manifestations are really, really rare in morphea. Maybe 5% or fewer people, depending on what you read, have internal problems. But she actually has one, because when we had her stand up to take this photo, what you can see is she has an effusion here with her knee. So an inflammatory kind of synovitis or inflammation of the joints, if not frank arthritis, are one of the internal manifestations of morphea, but they're actually terribly rare. We see them maybe in about 5% of our patients, and it's frequently the children with the linear lesions. What's interesting is these can arise often, as in her case, when the skin lesions are actually inactive, and they can arise later. So we keep close tabs on this. The good news is it's typically quite mild and can be easily treated with anti-inflammatory drugs, so it is not usually of the severity, say, of rheumatoid arthritis. The other thing this photo illustrates is because she had severe involvement of her leg during a time of rapid growth, you can see here her hips are uneven because this leg is slightly shorter than the other, and that goes to the fact that when you have this tight bound down area when you're trying to grow, it actually inhibits the growth. So again, good to catch when active to avoid this sequelae. So internal manifestations. So we talked about scleroderma, the GI system, the bowels, the heart, the lungs, the kidneys. So this is very different. One of them that has recently come to light, and this is a patient that I have followed, and it's actually involvement of the underlying muscle, underlying lesion. So this young woman has had morphea since childhood and has had, over time, gotten new lesions, which is not all that uncommon. In fact, we recently published a paper talking about recurrence of morphea. We just have one accepted talking about adults with pediatric onset disease, and we do see that it reactivates from time to time. When she came in, she's very active and did a lot of yoga and Pilates, and she told me that her leg was feeling very, very tight and painful as she was trying to do this. And we did an MRI, and what we actually saw is that she had involvement of the fascia here of her leg, kind of underlying this area of morphea. And what this actually is thickening of her fascia. So when you see kind of internal involvement, what it can be is involvement of the fascia, which is what kind of is overlying your muscle, or the muscle underlying morphea with inflammation or thickening. And when we see this, it's a sign to us that these patients actually need treatment with an oral medication, because obviously a cream or a light treatment is not going to reach down to this area. So this is called a coup, which is the cut of the sword in French, which is just a form of linear morphea of the face. That's all it is. It's particularly devastating because of the location, of course, on the face, which is so cosmetically sensitive. So this is a young boy, and he had a long-standing lesion of a coup here, you can see. But when I see patients with a coup, in addition to looking at their skin lesion, I always compare the contour of the two sides of their face. The reason why is because people with linear morphea of the face, if they get the deep involvement, just like we talked about, like my patient with the leg, Their deep involvement actually causes what they call hemifacial atrophy or perirhomber. All hemifacial atrophy or perirhomber is involvement of the fascia and the muscles of the face, rather than, in this case, we had involvement of the muscles and the fascia of the leg. The problem is this is someone's face, and so the cosmetic impairment is that much greater. And you can see here, it's relatively subtle, but if you look, I always look at the contour of the cheek, the angle, the straightness of the nose, and then the line of the mouth here and the line of the chin. And if you look at him very carefully, you can see his nose kind of slightly is deviating this way. The contour of this cheek and his eye is just slightly different on this side and this side. And his chin is a little different. And it's magnified if you actually look at him from this angle, you can see the amount of tissue he's lost on this side. But this is subtle. This, was not something that was obvious or anyone noticed because this happened very gradually over time. And it's also, if you are very focused as a provider on checking on this, and you don't look for this, you don't necessarily see it. So this is something if you or a family member have these facial lesions, it's important to look at. You can even take photos like this yourself and kind of look for it. The other time we find this is people who have like grandma come visit who hasn't seen the children for several months or a year, and grandma comes and visits, and I've had this happen repeatedly and says, what happened to so-and-so's face? And then they come in with this. And again, sometimes these can have been inactive for a long period of time. And typically what we do in this scenario, again, is an MRI, because I want to see if we have inflammation there that's actually treatable. Because again, if this had run its course and we just have the tissue loss without the inflammation, medical treatments won't be terribly effective. This is the other thing we talked about already, is you can kind of see, you can get deep Morphea lesions, and all this is the same thing as hemifacial atrophy, except it's occurring on someone's leg. And you can see it's very difficult to see. And what you actually this is apparent by peeling. And so what I did to do this photo is this is where this person had an incisional biopsy, but I actually felt everywhere that was felt thick and hard. And this was from an ultrasound study we did, but you can see that it extends all through the leg here. And usually when you see this and we have this very deep involvement, we know that this is involvement of the fat and possibly the fascia or muscle. That's really an indication, again, for oral treatments, because anything from the outside in is not going to reach to these areas. Eye involvement. Eye involvement is most common in patients who do have the lesions on their face, whether they be the linear lesions or the hemifacial atrophy. And you can see this little boy actually is involved going down to the eyelid. So one form of eye involvement is actually when the lesions involve the eyelids, and that can be a problem because it can give you problems in closing your eyes. So again, an indication for aggressive treatment if it's active to try to prevent damage to the eyelid. And here you can see he has involvement going up into the scalp. The other thing is there was a study that was done that was published in the British Journal of Ophthalmology that about 3.2% of children had eye involvement, and most of them had the coup sabre linear morphea, but some of them did not. And some are related to the direct extension of the morphea to the eye area, like to the eyelid or the muscles around the eye. But others actually were more inflammation of the eye, something called uveitis. That usually presents with redness and a foreign body sensation in the eye, so it feels like you've always got something in your eye. So currently the standard is for patients who do have this involvement of the head or face is for them to get a baseline eye exam with an ophthalmologist, so an MD eye doctor, and I usually ask them to repeat that annually. And again, this is very rare. It's only about 3.2% of individuals. So again, very different from scleroderma because these internal manifestations we're talking about are occurring in 5%, 3.2% of people, whereas scleroderma, the internal manifestations are different and much more common. So again, this is another example of a patient with an effusion of her knee. She had very deep Morphea lesions, so you can see these, you can just see very faintly the outline, and she told us that she had a lot of stiffness and kind of morning pain and typically been very active, but not as active as in the past. And as we were looking at her, you can see here this knee is very swollen, so she actually had an effusion, which is fluid in the joint of this knee. So again, this can occur, but it's rare, and generally can be treated with immunosuppressive medications. So labs, this is the big thing because a lot of people order labs when they see patients with morphea. But unfortunately, labs are not really very useful in morphea. And this is our own study that was published in the Archives of Dermatology. And we looked at a number of things, including anti-nuclear antibodies, double-stranded DNA, single-stranded DNA antibodies, and anti-histone antibodies, which have been reported by others in the literature as being important indicators of people who might have more severe morphea or people who have active morphea. What was different about our study is we had more patients, and we actually did all the lab testing in one research laboratory, versus all the other studies have actually just used what was used clinically, and that's a problem because it's done in different labs oftentimes, and so the rates of detection can differ. And so what we found is generally that these antibodies were not very helpful at all, because these are measures of disease severity. Up here you can see functional limitation, extensive body surface area, so involving a large part of the skin. These are measures of skin thickness. These are measures of disease activity, and these are measures of disease damage. And what all these NSs mean is that none of these antibodies, or the presence of them in people with morphea, was associated with any clinical outcome except for these very few areas here in terms of anti-nuclear antibodies and maybe a little more extensive body surface area. So the bottom line is that right now, unfortunately, we don't have any laboratory tests that A, identifies someone as having morphea, or B, identifies them as being at risk for more severe or more mild morphea, or C, identifies them as having active or inactive morphea. So really, the diagnosis and management of morphea right now is very much based on what we see with our eyes or what we can ascertain with imaging like MRI or ultrasound. And this is basically talking about that. So another thing that people frequently ask me about is what will happen over time with my morphea, which is a natural thing, obviously, you want to know. And in medicine, we call that the natural history of the disease. And until recently, the natural history of morphea was very poorly defined because no one really followed people over time. And I'm happy to say that thanks to the patients that have been so kind and helpful and have enrolled in our cohort, we're actually beginning to get some information on the long-term history or natural history of morphea. One thing that we've reported now 2 or 3 times in the literature in different forms is that for some people, morphea can be progressive over many years. And what that means is they can have periods of activity where they have new or expanding lesions. They can be treated or sometimes even not treated and the lesions become inactive, but then at some point down the road, they have a new episode of activity. Unfortunately, we can't give you a great percent in terms of how many people have this, because part of my problem is I have what is called a selection bias, in that the people who are going to come to see me kind of tend to be the ones that are having active problems. So I can't give you, with all people with morphea, how frequently in that group of people you'll see reactivation, but what I can tell you, it can occur. And this is just an example. This is a patient who has had many lesions develop over time. She's had this since she was a teenager, and then she came in with this spot on her neck. And these are multiple linear lesions. You can see hyperpigmentation and atrophy in the old lesions, so these are inactive, but this new lesion on the neck has redness surrounding it, and that's an indicator that it's new and active. And then some of the older lesions here. This is actually a study that we recently published, and we actually wanted to look at the time to recurrence of active lesions for basically 3 treatment groups that came in and into our cohort early on. The first group is actually 15 patients who we did not put on any treatment, and the reason why is because their morphea was completely inactive, but what we did is we took photos and followed them. The second group had active, moderate to severe morphea, so they met criteria to receive methotrexate and steroids, which is the current recommendation for active, moderate to severe morphea. And the third group had milder morphea or mild moderate morphea or were not candidates for methotrexate and steroids, and they received UVA1 phototherapy. And so what you can see here is that the time to recurrence in this group from the time in which they had their initial visit to me, and in this group in the time of the last day of treatment here was about 20 months for the no treatment group with a range of 2 to 50, so huge range. So it can be very variable. 37 months for the methotrexate and corticosteroid group with a range of 16 to 56 months, and about 16 months for the UVA1 group with a range of 40 to 63 months. So you can see that in this group of patients, we actually did see recurrence of active lesions, and treatment did not seem to really affect that, although we did seem to see a bit higher recurrence with the UVA1 group than with the methotrexate group, but it was pretty similar to the no treatment group. What this tells us is probably people who get UVA1 therapy, it's effective at shutting down the morphea then and there, but after it's discontinued, you have to be cognizant of the fact that it can reactivate. And that's not all that different. Phototherapy, like UV phototherapy, is used for a lot of skin conditions like psoriasis and eczema, and the same is true in that category. Different treatments can induce longer or shorter times of remission. The other thing we were curious about is if there were any differences in terms of the features of the patients, in terms of their morphea subtype, other treatments that they had, if they had had treatment failures and such, that predicted whether they would have recurrence of their morphea. And the only thing that we found is the subtype of their morphea, you can see, did not make a difference in terms of time to recurrence. So it does not appear that one subtype of morphea is more prone to recur versus others. The thing that was strongest in terms of recurrence is people who had systemic immunosuppressants in the past as a history, those that had oral vitamin D in the past, or those who had treatment failure. So that doesn't mean that having had systemic immunosuppressants makes your disease necessarily recur. What it probably means is people who had treatment failures, systemic treatments like this, had more severe morphea to start with, and so the people who had more severe morphea to start with, this also means they had prior episodes of activity, was predictive of more problems in the future. And this is just an illustration of the time to recurrence of active morphea in our three groups. You can see placebo indicates the no treatment group here, and then methotrexate and corticosteroid is here in red, and then the phototherapy UVA1 is here, and this is months going out from time point 0. You can see here at time point 0, no one had recurrence, so 100% were inactive, and then this is the percent that are going to be active moving forward. The thing to take away from this is that you can see this is 24 months, or about 2 years. And so most people who are going to have recurrence, and then the lines kind of stabilize. So most people, if they have recurrence here, tend to have it within the first 2 years of discontinuation of treatment, and then it seems to stabilize out. The caveat being that as we move out further here, the number of people we have to follow has declined, and so over time we'll see if this actually bears to be the truth. But at least from this, it seems that if you don't have recurrence in the few years after a bout of activity, the likelihood of recurring seems to decrease. So again, here, this is an analysis to try to figure out what factors might be predictive of someone recurring or having recurrent morphea. And what you can see here is that, again, the treatments have different times of recurrence. So a few words about treatment. There's a lot of problems in terms of treating morphea, unfortunately. A lot of things that are out there are really not proven to have any benefit for people with morphea because they're too small, they don't have a control group, and we talked about that the disease can go through periods of activity and inactivity without any treatment. So if you don't have a group that isn't receiving treatment, you can think your treatment is actually doing something for someone, but in fact the disease is just becoming inactive on its own, And until recently, we really had no way to measure if a therapy was helping someone. So, also, most of the older studies don't differentiate active from inactive morphea, and they don't address, we don't really know much about the ideal treatments for the uveitis and the inflammatory joint disease. And most treatments, we don't have long-term follow-up in, and until recently, we didn't know much about the natural course of the disease. So the bottom line is there's really no widely accepted therapeutic algorithm for people with morphea. And so what you see is huge variation depending on who you see, what type of doctor they are, and what their experience with morphea is. So this is a study that we published, and what you can see is that the treatment you get if you have morphea is going to differ a lot by whether you see a dermatologist or a rheumatologist, because people use what they're comfortable with. So if you see a rheumatologist, you're very likely to get methotrexate and or steroids, kind of irregardless of what type of morphea you have. If you see a dermatologist, unfortunately, you're going to very likely get a cream, irregardless of what type of morphea you have. And the problem is that creams are not appropriate for everyone, and methotrexate and steroids are not appropriate for everyone. So the best advice I have is you need to see someone with experience, because when we surveyed people who had experience, they were much more consistent with what is currently considered the current practice guidelines. Yes?
Have you ever had a problem with anybody using the methotrexate?
You mean in terms of side effects?
Yes.
Not in children. I find children tolerate methotrexate exceedingly well, probably because they don't have all the other conditions that you gather as an adult. In my adult population, we fairly frequently have to stop methotrexate due to elevation of liver enzymes.
Do you use the pill more than a shot?
I use the pill first and only use the shot if people are getting upset stomachs with the pill or the pill appears not to be working.
And a shot, where do you have them do it? In the leg or?
We do a subcutaneous, so the same way as you would administer insulin, so it can be either in the leg or the stomach, but it's the same subcutaneous, not in the muscle.
Oh, okay. Thank you.
Sure. And that's another problem is because there's no accepted route of administration for methotrexate or steroids. We don't have studies that tell us one way works better than the other, oral versus shot form. So, and I've got the 5-minute limit here. So the reason why I wanted to make such a big point about identifying active disease is because treating active disease is the interval of time where you can make a big difference. And you can see here, this is a patient of mine, and she had an active lesion of morphea on the breast. And you can see here's the collagen, kind of the yellowish white, and here's the inflammation around it. And this is a great patient to treat with UVA1 phototherapy, and we did, and you can see it largely resolved. So that's why we want to identify people when they're active. And this is the same picture you saw before of this patient with a lesion on her leg that was very early and largely inflammatory. And we started her on methotrexate and steroids. And you can see when she came back 2 months later, the red is turning to brown. And we call that post-inflammatory hyperpigmentation in morphea. And what that means is that activity is going away. And these patients, when you catch them early like this, oftentimes these resolve, and you can really, this is the only time where they really go away, where you can barely see that anything was there. If they develop more than this, it's very hard to get them to go away completely. So these are some of the current treatments that are out there. There's a slew of creams that people like to prescribe. I count phototherapy as topical because, again, it's outside in, and then a number of systemic treatments. And we'll just briefly go over these. So this is one thing I'd like to have you go away with, is that phototherapy is very underutilized for morphea, but there's actually good evidence that it works. And these are some studies that have been done. I should tell you that I'm greatly indebted to the Scleroderma Foundation because they have actually funded a randomized placebo-controlled trial of UVA1 phototherapy at our site. So that will actually give us much more information on how effective UVA1 therapy is. But there are a lot of studies that seem to indicate it's successful. And dermatologists who usually use this type of treatment tend not to think about it for people with morphea. And this is just an example of a patient I treated with UVA1 phototherapy. She already had a lot of sclerosis, but you can see she has inflammation surrounding this lesion. And we treated her, and you can see there's a resolution of the inflammation and some improvement of the sclerosis. But again, it didn't make it go away completely, but it converted it from being active to inactive, and we also saw some decrease of the tightening of her skin and improvement in the range of motion of her ankle. This is another patient, and she actually developed morphea kind of in her abdominoplasty scar. And we treated her with UVA1, so she became very tan. And then you can see her a couple of years out, and you can see that the appearance of the lesion has improved, but it has not gone away completely, and she's remained inactive for several years. This is another example of an early inflammatory lesion, which we treated that became post-inflammatory hyperpigmentation. And generally, when you see this, it will over time fade, and there will be very little residual left here. This is another patient with a linear lesion. She's in her 20s on the trunk. This is actually a bruise. She fell mountain biking. But you can see here this lesion is was fairly active at the time. Phototherapy makes it much darker and more obvious over the short term. But I just saw her back very recently, and this has significantly softened. So it did prevent it from enlarging, and it had induced a lot of softening, but again, it's not gone. These are some studies that came out of Germany for the treatment of morphea with UVA1. Again, you can see when they're very early and more red than anything else, they go away quite well. So, there are also other types of phototherapy called narrowband UVB. This is important because this is much more widely available than UVA1. So most places don't have UVA1 phototherapy, but most larger cities will have a dermatologist who has narrowband UVB phototherapy. And there's also UVA therapy. I bring this to your attention because right now methotrexate is the only drug that has proven to work in people with morphea in the form of a randomized controlled trial. And this is the trial right here. It was done in children. Everyone started off receiving prednisone for the first 3 months. And then one group had a placebo, i.e. a sugar pill. The other group received methotrexate. In the first 3 months, everyone improved. So prednisone early can work. The problem is in the group where they just stopped the prednisone and didn't give them methotrexate, they were far more likely to have recurrent spots of morphea. So the methotrexate was very important in preventing recurrence of the morphea, and is currently recommended for moderate to severe morphea. Cellsupt is another drug that is used for people who can't use methotrexate. We're not sure how well it works. I will tell you, we do not recommend the use of plaquenil or hydroxychloroquine. There's no support or evidence that it does anything for people with morphea. The same is true of oral calcitriol, which is a vitamin D derivative. So the take-home point is there are a lot of things that are frequently prescribed that are probably not very efficacious. The things that are known to be efficacious are UVA1 phototherapy, methotrexate, and some of the topical treatments like tacrolimus and calcipotriene. But the thing is you need someone with experience to know which is the appropriate treatment for an individual situation. Also, people who have a joint involvement need physical and occupational therapy. Sometimes there's a PM&R, physical medicine rehabilitation doctors that are very helpful. You can have loss of the subcutaneous fat pad of the foot, not true bony limb length discrepancy, and it's very important to get shoe inserts because the lack of subcutaneous fat or the limb length discrepancy put people off balance. And so over time, as they go through adulthood, they'll actually get a lot of joint damage. And again, orthopedics or bony abnormalities or contractures. And pathology is sometimes helpful because we can know where the majority of the morphea problem is occurring. This is all thick and collagen deep down in the skin, and up here it's relatively normal. And here, all the collagen is up here, and down here the skin is normal. So this person really would need something that is not a cream or phototherapy because it won't get down here. This person could potentially be treated with a cream or phototherapy because the problem is all up here where it could possibly reach. And so it can help to do these for that purpose alone. Although remember, this is what can confuse it, and you can't differentiate from scleroderma. So that is it. The points I'd like for you to take home are Morphea has distinct demographic and social features for scleroderma, and people with Morphea don't get scleroderma. Skin is really the predominant organ affected, so the majority of people with Morphea are otherwise healthy, but the devastating effects can be in function and cosmetic impairment. We don't understand a lot about the pathogenesis, but that is changing, thankfully. Blood tests are not helpful for Morphea. Individual spots can become inactive, but leave behind permanent damage, and the active spots are the ones that we want to target for treatment. Some people can have periods of activity and inactivity, others can just have one episode of activity. And treatment is best pursued by someone who has experience with patients with Morphea. So, and that's it. That's my email address. Time for a question or two, and unfortunately I have to go to the airport. So I also have some cards in the back and have my email address if I don't get to you. So.
Hey, Susie, can I ask you if people had individual questions that you could?
Oh, sure. Okay. All right.